Good morning, everybody. Okay, so we're going to go over the changes in A, I, J, and O this morning. I just want to reiterate a little bit of what Bridget said, which is if you take out handout number 3, those are your acronym lists. Handout number 4 is your action plan. And handout number 13 is one that Bridget did not mention, but it is the practice scenarios that we'll be going over during this presentation, so you might want to have those handy as we go through some of the Slido questions. Okay. So as always, we start with a couple of slides of the acronyms that are going to be used in the presentation. So this is the first set of acronyms, and this is the second set. And now we'll move on to our objectives. So after participating in this session, you should be able to describe the changes that have occurred in sections A, I, J, and O, and knowing enough to be able to answer some of the practice coding scenarios. And actually some of the information that you'll learn during this presentation will also help you in the PDPM case study that John and Jen are going to be leading you on this afternoon. So let's start right off with section A. So the intent of section A is to obtain key information to uniquely identify each resident, the home in which he or she resides, and the reasons for the assessment. So facility provider numbers had a couple of changes here, and it was mostly for clarification. Item A0100B, the CMS certification number, the addition here is that if A0410 equals 3, which is the federally required assessment, the CCN number must be there. It cannot be blank. And for item A0100C, which is the state survey agency, was actually added to this bullet, just to let you know that it is the state survey agency that assigns this number. You probably already knew that, but it was just for clarification. So the next item is A0300, and that is the optional state assessment. This slide shows you the two different item set snapshots. If you remember from yesterday morning's presentation, the top snapshot of A0300 is what you'll see on every other item set except the OSA. The second snapshot that's on that slide, the bigger one, allows you to identify the type of assessment that you are completing for the state. So you'll only see that item on the OSA. And also, as I mentioned yesterday, the OSA is state optional. It's not federally required, and it was created to allow providers the ability to collect data required for the state payment reimbursement. It's important to note that the OSA is a standalone, and it cannot be combined with any other assessment. So the coding instructions are very straightforward for the OSA. If your state requires you to complete the OSA, you're going to enter yes, which is 1, and if not, you're going to enter 0, which is no. And when you enter all of the information into the OSA, what it's going to do is it's going to help calculate the HIPS code for state payment purposes. We ask if your state, and if you don't know if your state is going to be using the OSA, you might want to talk to your state agency. If you already know that your state is going to be using the OSA, you need to contact them to talk to them about the completion requirements for the OSA. So the other thing that was mentioned at the last training was that you are going to be able to submit the OSA to Keys ASAP. And it'll also give you a validation report. So you'll have that. We had some folks asking, well, that doesn't really make sense. Why would we send that to Keys ASAP? That's kind of how it works now. So when you send your assessments into Keys ASAP, they accept all of the assessments, and then they push out a state file. So it's kind of what happens now. And that's also one of the reasons why CMS doesn't like you to submit Medicare Advantage plan information, because all of it goes into that MDS file that gets pushed out to states, and the states can't have that. And actually, CMS can't have that information. Okay. So A0310 type of assessment. And this will look familiar to you from yesterday. Basically, the changes here, of course, are in the PPS area, which is A0310B. Quite a few of the assessment types have been removed, and we know why. It's because they're not needed under PDPM. And this slide just highlights for you that section itself. So what we're left with are just those 3 response codes for the 5-day PPS, which is 01, the IPA, which is 08, and 99, which is none of the above. The coding instructions were also updated to accommodate the new IPA, which again you learned about yesterday morning and which you'll hear a little bit more about in John's presentation later this afternoon. And all the coding instructions for all those item sets that no longer exist were also removed from the manual. For item A0310E, there were a couple of small clarifying edits made there. The first was to amend the coding tips to accommodate the IPA. You're going to code A0310E as 0 for an IPA, and that is because the 5-day would have to have already been completed in order for an IPA to be completed. So if you remember from yesterday morning, the ARD for an IPA can't precede that of a 5-day. And that makes sense, right? Because the 5-day has to be completed before the IPA. The second clarification here is in the note. The acronym OBRA was added here to say that the first submitted assessment may not be an OBRA admission assessment. And we had some folks ask why that is. Well, if you recall, if you have a newly certified facility, if an admission assessment was already completed prior to the certification date, the facility would just continue on with the OBRA schedule, and the next expected assessment using the actual admission date as day 1. So this is referring back to that policy. The next assessment wouldn't be an entry in OBRA, right? It could be a quarterly, it could be a discharge. So when the facility submits that next assessment, all you get is that sequencing warning saying, you know, this seems like out of order to us, but you still submit that assessment. So that's what this is referring to. It's referring back to that policy. Okay, A0310G, type of discharge. The only change here really was that a coding tip was added to enter the number of the type of discharge that you're going to complete. So 1 for planned, 2 for unplanned. Again, something you already knew, but it wasn't in the manual. So here is the new item for interrupted stay. The item number is A0310G1, and this is associated with the PDPM. Here is a snapshot of that new item, which, as you can see, again, is a very simple item, yes, no response. You'll see this item on the comprehensive for an entry, quarterly and PPS assessments, nursing home and swing bed, and the OBRA discharge. In this item, you'll indicate whether or not an interrupted stay has occurred. You're going to code 0, no, if an interrupted stay did not occur, and code 1, yes, if an interrupted stay did occur. So now we're going to go a little bit more into the interrupted stay policy. I gave you the definition yesterday. So an interrupted stay is a Medicare Part A SNF stay in which a resident is discharged from SNF care, that is, the resident is discharged from a Medicare Part A covered stay, and subsequently resumes SNF care in the same SNF for a Medicare Part A covered stay during the interruption window. The interruption window is the first non-covered day following a Part A covered stay, ending at 11:59 p.m. on the 3rd consecutive non-covered day following a Part A stay. And when we talk about resumption of care, or the Part A covered stay, we mean that if a resident was in a Medicare Part A SNF stay and they're discharged from Part A, the resident must resume Part A services or return to the same SNF to resume Part A services if they were physically discharged by 11:59 p.m. at the end of that 3rd calendar day. In order to be considered an interrupted stay, the conditions that I spoke about on the last slide and shown here a little bit more abbreviated need to be met. So the resident has to be discharged from a Part A stay, and they either return to the facility to resume Part A services in the same SNF, or resume care if they remained in the facility by 11:59 p.m. at the end of that 3rd day. The subsequent stay following an interruption is considered a continuation of the previous Part A stay for the purposes of the variable per diem schedule and for PPS assessment completion. So what this means is the assessment schedule and variable per diem schedules do not reset after an interrupted stay, and that's because the Part A stay doesn't end. So the variable per diem and PPS assessment completion schedules just continue from the point prior to discharge. And John will talk a little bit more about that in his presentation. As I've stated, the interrupted stay policy can apply to residents who are either physically discharged or those who remain in the facility. The information here on this slide shows some of the reasons for which the discharge from Part A can occur. So these can include the resident leaving against medical advice, or the resident could be transferred to acute care, a psychiatric hospital, outpatient facility, due to a change in condition or for an evaluation and treatment, or the resident could go to another type of facility, like a SNF, an assisted living, a private resident, or a home health services. So remember, if they do get discharged from Part A and they leave the facility, it would only be considered an interrupted stay if the resident returned to the same facility within that 3-day window. If they don't return within that 3-day window, it's not an interrupted stay. On this slide, we see some examples of situations where a resident remains in the facility, but the Part A stay stops being covered under the PPS benefit. These situations could include the election and revocation of the hospice benefit, refusal to participate in rehabilitation, and there's no other daily skilled need. The resident's payer source changes from Medicare Part A to another payer source like Part C or private pay, private insurance, hospice. So remember again here, if the resident does get discharged from Part A, it would only be considered an interrupted stay if the resident resumed Part A services within the 3-day window. If they did not, it's not an interrupted stay. So let's look at some examples of what would be considered an interrupted stay and what assessments or records are required on discharge and then resumption of Part A. One example of an interrupted stay would be if a resident is discharged from SNF care, remains in the SNF, and resumes Part A covered stay in the SNF within the interruption window. In this instance, no discharge assessment, OBRA or Part A PPS is required, nor is an entry tracking record of 5-day required on resumption. The subsequent stay is considered a continuation of the previous Medicare Part A covered stay. This is considered an interrupted stay because the criteria were met. There was a discharge from Part A, and the resumption of Part A was within that 3-day interruption window. Make sense so far? Okay. Another example of an interrupted stay would be if a resident physically leaves the SNF and returns to resume Part A covered services in the same SNF within the interruption window. On discharge, no Part A PPS discharge is required because in this situation, the Part A PPS stay doesn't end, right? However, because the resident physically left the facility, your OBRA rules take over here. So you have to complete an OBRA discharge in this instance. Now, of course, you're going to decide whether it's discharge return anticipated or not anticipated. Mostly, you're probably going to say return anticipated, I would think. So on return to the same SNF, an entry tracking record would be required, but no 5-day would be required. And that is, again, because the interrupted stay doesn't cause the Part A stay to end. And the subsequent stay is still considered that continuation of the Medicare Part A stay. One thing to remember is that when a person physically leaves a facility, again, you have to follow those OBRA rules. So don't get them confused with what's required for interrupted stay and not, and what's required for OBRA. Okay. Now let's look at another couple of examples when there is no interrupted stay. If a resident is discharged from SNF care, remains in the SNF, and does not resume Part A within that interruption window, an interrupted stay didn't occur. In this situation, a Part A PPS discharge is required, and if the resident qualifies and resumption of Part A occurs within the 30-day window allowed by Medicare, a 5-day would be required. But no changes would be made to the OBRA schedule at all. It would just continue from the resident's original date of admission, which you would see in A1900. The subsequent stay would be considered a new Part A stay. This is not considered an interrupted stay because both of those criteria I mentioned weren't met. Even though there was a discharge from Part A, the resident did not resume Part A services within that 3-day interruption window. And finally, if a resident physically leaves the SNF and does not return to resume Part A services within the same SNF within the interruption window, again, an interrupted stay did not occur. In this situation, both the OBRA discharge assessment and the Part A PPS discharge assessment would be required, and of course, they can be combined. If the resident did return to the same SNF, that subsequent stay would be considered a new Part A stay, and an entry tracking record and 5-day would be required. Now, on the OBRA side of the equation, an OBRA admission would be required if the discharge was completed return not anticipated. If the discharge was return anticipated, no OBRA assessment would be required. Does that make sense? Okay. This is not, again, considered an interrupted stay because the criteria were not met for interrupted stay. Even though there was a discharge from Part A, the resident did not return to the SNF to resume Part A services within that 3-day interruption window. Okay, we're going to try some practice scenarios. So if you have your slider ready, that would be great. So Mr. J was receiving skilled services in a SNF under Medicare Part A for rehabilitation. Mr. J fell and was sent to an acute care hospital for an evaluation. Since staff expect Mr. J to return to the facility, he was discharged, return anticipated. Mr. J left the SNF on 4/23 at 4 p.m. and returned to the same SNF to resume skilled services under Part A on 4/25 at 7 p.m. So the first question is this an interrupted stay? Choose A for yes or B for no. Okay. Got quite a few people coming in right away with A. I'm going to wait a little bit longer here. Numbers continue to climb, so I'm going to wait just a couple more seconds, but it looks overwhelmingly like A might be what folks think the answer is. Okay, so we'll move on to the correct answer. And it's A, yes, it is an interrupted stay. And of course, the rationale here is that the interrupted stay policy applies to residents who leave the facility and are discharged from Part A and return to the same SNF, resuming Part A services within a 3-day interruption window. Transfer to an acute care hospital is part of this policy. And additionally, the 2 criteria for interrupted stay were met. It's that Mr. J was on skilled services under Part A when he transferred to the acute care hospital, and he returned to the same SNF before the end of that 3rd calendar day, which is within that interruption window. Okay, here's another question associated with that scenario. Which of the following assessments are required when Mr. J leaves the facility? Is it A, the OBRA discharge, B, Part A PPS discharge, C, combined Part A PPS discharge and OBRA discharge, or D, none of the above? Okay, got quite a few people choosing OBRA discharge. Got some numbers changing still, so I'm just going to wait a little bit longer here. Okay, let's move on. See what the answer is. Correct answer is A, OBRA discharge. That's right. And the rationale here is that because Mr. J had an interrupted stay, his Part A PPS stay did not end, and therefore the Part A PPS discharge was not required. However, because he physically left the facility, the OBRA discharge assessment was required. Okay, we have one more question associated with this. Which of the following assessments or records are due when Mr. J returns to the facility to resume Part A services? Is it the 5-day assessment, the OBRA admission, an entry tracking record, or is it A and B, which are 5-day and an OBRA admission? Okay, we've got overwhelmingly folks looking at the entry tracking record. And it doesn't look like the others are changing much. So I think we can go on to the answer. And the answer is C, entry tracking record. That's correct. And the rationale here is that the entry tracking record is required anytime a resident leaves and returns to the facility he or she was discharged from and returns to the facility within 30 days, right? That's your typical entry tracking record requirements. So since Mr. J was discharged, return anticipated, an OBRA admission wasn't required, right? Had he been discharged, return not anticipated, an OBRA admission would have been required in this situation. And then on return to the SNF, no 5-day was required because Mr. J's Part A PPS stay did not end because he was in an interrupted stay. As far as the payment, the resumption on the variable per diem schedule would come from the day of discharge, again, because the Part A stay did not end. Okay. So let's move on to A0410, which is a unit certification or licensure designation item. The change in this item is under Code 1. The coding instructions were clarified to add neither CMS nor the state has authority to collect MDS information for residents on a unit. This is pretty much what it always meant. So basically, again, the addition of CMS here is just to clarify that neither CMS nor the state can receive that information. The item rationale for A0410 was updated basically to state that nursing homes should only be submitting MDS for those residents who are on a Medicare or Medicaid certified unit, and that swing bed facilities should only be submitting MDS assessments for those whose stay is covered by Medicare Part A benefits. So that's new. Okay, A0600, Social Security and Medicare numbers. There have been a couple of changes here. The update in A600A is that a valid Social Security number should be submitted in this item whenever it's available. And that's because they need this on the back end for resident matching. So that needs to be as accurate as possible. The update made in A0600B was that, was that the parenthetical statement that was there, which was or comparable railroad insurance number, was removed, and the coding instructions were updated to add code 08 for the IPA, and to say that A0600B must be a Medicare number. The definition also changed to state that the Medicare number is different. It used to say it may be different from the Social Security number and may contain both of those, both letters and numbers. So A0700, Medicaid number. A coding instruction was just added here to include that a letter can also be part of that number. A0800, gender. This just had one clarification, and that was that the coding instruction was updated to say that the resident gender has to match what's in the system on the Social Security side. A1500 and A1510, these are the PASRR items. So the parenthetical statement, mental retardation and federal regulation, was removed from the item set in both A1500 and A1510. This language had already been removed from the text of the manual, and we're just making sure that the item set matches that now. The next item is A2400, which is the Medicare stay. In this snapshot, what you'll notice is up at the top, right under where it says 2400 Medicare stay, there's a new subheader. And the subheader says complete only if A0310G1 equals 0. This corresponds to the first coding tip here on this slide and relates to the interrupted stay policy. A2400 is only completed when there has not been an interrupted stay. And that's because when there is an interrupted stay, the subsequent stay is considered a continuation of the Medicare Part A stay. So it's not a new Part A stay. When the over-discharge assessment indicates that an interrupted stay has occurred, that is if A0310G equals 1, items A2400A through A2400C are inactive. You won't see them active on your item set. Okay, moving on to section I, active diagnoses. The items in this section are intended to code diseases that have a direct relationship to a resident's current functional, cognitive, mood, or behavior status, medical treatments, nursing monitoring, and risk of death. And of course, the important functions of the MDS are to generate an updated and accurate picture of a resident's current health status. Starting with A0200, this item was used as a risk adjuster for the new skilled nursing facility quality reporting program functional outcome measures. And those, as you learned yesterday from Alice, include quality measures that look at self-care and mobility discharge scores and the changes in those scores. I0020B is also used in PDPM to identify the primary diagnosis clinical category. So the revisions to these items you can see highlighted on this slide. The older version is in the upper left corner and the new version is in the lower right. Since I0020 is associated with the Part A stay, it's completed only if A0310B equals 01, which is the 5-day. One of the revisions to this item is the subheader, and that is that the item will also be completed on an IPA. So you'll see there A0310B equals 08. There have been 3 additional revisions in this item, as you can see in the snapshot to the lower right. The I0020 response code number 14, other medical condition was removed, as was I0020A. And now you just have there I0020B, which is now where you're going to enter your ICD code. So the item rationale here is that disease processes can have significant adverse effects on a resident's functional improvement and therefore improve their quality of life. Under planning for care, this item is going to identify the primary medical condition category that best describes the primary reason for the admission to the SNF stay so that you can plan for the resident's care. In order to complete this item, you need to identify the resident's primary medical condition category that best describes that primary reason for the Medicare Part A admission. The places that you'll look for this information can vary, but generally you'll find resident diagnoses in any one or a combination of the medical record sources listed on this slide. The most recent history or physical, a transfer document from the prior acute stay, discharge summaries, progress notes, and other resources as you have them available to you. Most frequently, but not always, the diagnosis you'll get from the acute stay. And of course, although open communication regarding all of this information is really important, it also needs to be documented. So make sure that you have your documentation aligned with the resident information that's coming in. In order to complete I-020, the first step is to identify the diagnoses associated with the SNF admission and assign it to one of 13 primary medical condition categories that best describe the primary reason for that admission to the SNF. It may be that the resident has some documented diagnoses for which you believe more than one of these medical conditions could apply. What you're going to do is choose the one that has the most effect on the resident's health and function the most. So the first 7 categories here are stroke, non-traumatic brain dysfunction, traumatic brain dysfunction, non-traumatic spinal cord dysfunction, traumatic spinal cord dysfunction, progressive neurological conditions, and other neurological conditions. This slide has the remaining 6 of those categories, which are amputation, hip and knee replacement, fractures and other multiple trauma, other orthopedic conditions, debility, cardiorespiratory conditions, and medically complex conditions. So once you indicate the resident's primary medical condition category, you're going to enter the ICD code for that condition in I0020B. Remember that the ICD code in the item is used in the PDPM to identify the primary diagnosis clinical category. Again, this item is completed on the 5-day or on the IPA. You will still include the primary medical condition code in item I0020 in section I0100 through I8000, which are the active diagnoses in the last 7 days. This slide and the following 3 show the response codes for each of the 13 primary clinical categories with the examples included. I'm not going to go through all of the details on each of these, but they're here for your reference. They're also obviously in the manual. So these are the examples for codes 01 through 03, and for code 04 through 06, and for 07 through code 10. So there is one thing that I do want to point out about code 10, is that if a hip replacement is secondary to a hip fracture, you're going to code it as code 10 fracture. You're not going to code the hip replacement code. You're going to code it under fractures under 10. And then code 11 through code 13. We did have a question come in about where you would what category you would choose for a circulatory surgery or digestive surgery. And for circulatory, you would code 12. That would be under debility cardiorespiratory conditions. And for digestive, you would code that under 13, medically complex. Okay. Let's look at some practice coding scenarios for I0020. In these practice scenarios, you're going to notice that there are some ICD codes provided there. And I just wanted to let you know that they're just examples. There could be other different ones, but these are the ones that were chosen for these particular scenarios. So Mr. K is a 67-year-old male with a history of Alzheimer's, dementia, and diabetes who was admitted for Part A after a stroke. The diagnosis of stroke, as well as the history of Alzheimer's, dementia, and diabetes, is documented in Mr. K's history and physical by the admitting physician. So how would you code I0020? Would you code it under code 01, which is A, code 06, B, code 12, C, or code 13, D? Okay, looks like an overwhelming amount of people are looking at stroke. Everybody good? We're well over 335. And I do encourage the people that are watching online to also participate, if you can. Okay, looks like we can go on to the answer. And yes, the answer is code 01, stroke. The rationale is that the physician's history and physical documents the diagnosis of stroke as the primary medical reason that resulted in Mr. K's admission to the SNF. Remember, item I0020 is not asking why the resident is skilled in the SNF. It's asking for the diagnosis that best represents the primary medical condition category that resulted in the resident's admission to the SNF. So keep that in mind. As noted here on the slide, they could have used ICD code I69.051, which is hemiplegia and hemiparesis following a non-traumatic subarachnoid hemorrhage, to code the ICD code. Okay, here's the second practice coding scenario. Mrs. H is a 78-year-old female with a history of hypertension and a hip replacement 2 years ago. She had an extended hospitalization for idiopathic pancreatitis. She had a central line placed during the acute care stay to receive total parenteral nutrition, or TPN. During her stay, Mrs. H is being transitioned from taking nothing by mouth and receiving TPN with the goal of being able to tolerate oral nutrition. The hospital discharge diagnosis of pancreatitis, hypertension, and malnutrition was incorporated into Mrs. H's medical record. So how would you code I0020? Would you choose A, code 9, B, code 10, C, code 11, or D, code 13? Wow. Quite a few right out of the gate with D. I'm just going to wait a couple more minutes here. Looks like people are still responding. Okay, let's move on to the answer. And yes, the answer is code 13, medically complex conditions, which was D. So I0020 would be coded as 13 medically complex conditions because Mrs. H had hospital care for pancreatitis immediately prior to her SNF stay. Her principal diagnosis of pancreatitis was included in the summary from the hospital. The surgical placement of a central line doesn't change her care to surgical care because it's not considered major surgery. And again, the ICD code here that was provided for this example was K85.00, which is idiopathic acute pancreatitis without necrosis or infection. Okay, now let's move on to I5900, which is bipolar disorder. And as you can see in the snapshot in the upper left corner of the slide, the label of I5900 says manic depression bipolar disease. This has just been simply revised to say bipolar disorder, which is more appropriate, and that's seen on the snapshot in the lower right-hand corner of the slide. Okay, we're on to section J. There were a couple of small changes in items J 1800 and 1900, and we have 2 new items in this section to look at as well. So under the intent statement, section J was updated to reflect those new items in this section. So the intent statement now reads that the items in this section assess dyspnea, tobacco use, prognosis, problem conditions, falls, prior surgery, and surgery requiring active sniff care and surgical procedures. So there is a couple of changes in J 1800, and they relate to falls. The coding instruction for code 0 no in 1800 was updated to allow for new skip pattern. So you see that new skip pattern highlighted on the screen there. You notice now if you code 0 no, you're going to skip to the swallowing disorder item, which is K0100. If you're completing a 5-day and code 0 no, you're going to skip to J2000, which is the prior surgery item. So obviously what you're seeing there is for the 5-day. So J1900, a couple of more changes here in this section, and they're in the examples. This is just a reminder for you of what J1900 looks like. This item captures the number of falls since admission, entry, or re-entry, or prior assessment, whichever is more recent. So in example 1, there was language added to clarify that Mrs. K slipped out of her wheelchair onto a dining room floor, and that she did have an assessment to make sure she was okay. So there wasn't any language in there that talked about an assessment being completed. So it was added that a range of motion assessment was completed prior to her being assisted back into the wheelchair, which indicated no injury, and that shortly after the fall, the staff completed a skin assessment to assure there were no injuries to her skin. The coding and the rationale for that example did not change. And then for example 5, this example supports the idea that when a resident falls, an injury may not necessarily show up immediately after, and sometimes you may need to go back and correct an assessment that's been submitted to acknowledge that an injury did occur during that time frame. So in the example that's in the manual, the resident fell on his right hip and the quarterly assessment was completed and submitted, showing that the resident had no injury because the assessment of the resident and the initial x-ray didn't show any injury. But a few days later, the resident complained of increasing pain in the right hip and had difficulty ambulating, so a follow-up x-ray was completed, and that showed a hairline fracture of the hip. The physician noted that that fracture was indeed attributable to the fall that occurred during the look-back period of that recently submitted quarterly assessment. So when we look now at the coding for the example, the rationale and the coding for the modification of the quarterly assessment did not change. What did change was the addition made in the original coding to clarify that J1900C, major injury, was originally coded as 0, none, on the quarterly that was originally submitted. So the overall rationale for coding did not change, but it's provided here for context, so I'm going to summarize it. So even though the extent of the injury didn't present right after the fall, it was directly related to the fall. And since the assessment was already submitted to Keys ASAP with an inaccurate code of no injury, the SNF had to go back and modify that quarterly assessment to reflect that there was an injury sustained during the fall that occurred during the look back of that quarterly assessment. So let's move on to the new item, J2100, recent surgery requiring active sniff care. J2100 would only be completed if the assessment is a 5-day, which is A0310B is 01, or an IPA, which is A0310B equals 08. If you answer J2100 as 1 yes, then you'll complete the other new item in this section, which is surgical procedures, and those are items J2300 through J5000. Looking at the item rationale for J2100, a recent history of major surgery during the inpatient's stay that's directly prior to the resident's Part A admission can affect a resident's recovery. So it's important information for you to know. This item identifies whether the resident had a major surgery during that inpatient stay that preceded the resident's Part A admission, which will require active care while that person is in the SNF. In order to complete the assessment, you will, as always, talk to the resident, and family or significant other about surgical procedures that occurred during the inpatient hospital stay that immediately preceded the party admission. You're also obviously going to review the medical record and information that comes to you from the inpatient hospital stay. And similar to I-0020, you're going to look at all those same medical record resources to get that information. Coding of J2100 also should be supplemented and supported by the documentation that you have in the medical record. So to code J2100, you are going to enter no, 0, if the resident did not have major surgery during that inpatient stay that preceded the party admission. And you're going to code 1, yes, if major surgery did occur. You're going to code 8, unknown, if you don't know or can't determine if there was a major surgery in that prior inpatient stay. So the coding tips here in J2100 refer to the criteria that constitute major surgery. In J2100, they're similar to what we have in J2000 prior surgery, but the difference there is the time span. So in J2000, we look at 100 days prior to admission to the SNF for surgery. But for J2100, major surgery refers to a procedure that occurred during an acute care hospital inpatient stay of at least 1 day and 30 days prior to the admission to the SNF. And the surgery did have to carry some degree of risk to the resident's life or potential for severe disability. So now let's look at the second new item in J2300, surgical procedures, which are J2300 through J5000, and how this interacts with J2100. So this is just a partial snapshot of what the item looks like. As you can see from this snapshot, there are surgical procedures listed that are grouped under major headings, such as major joint replacement, spinal surgery, other orthopedic surgery, and so on. There are other headings not shown here that include cardiopulmonary surgery, genitourinary surgery, and other major surgery. This is a check all that apply item, so you are going to check all that apply for the resident. As you can see here for each of the procedures, there are examples provided. And as we said previously, this item is only completed if J2100 is coded 1, yes, which means that the resident did have a major surgery requiring SNF care. The item rationale for J2300 through J5000 is essentially the same as in J2100, and that is that a recent major surgery can affect a resident's recovery, that this item identifies whether the resident did have a major surgery during the inpatient stay immediately prior to the admission to the SNF. So there's a two-step process to determine whether or not the surgery identified requires active care in the SNF. And the first is to identify recent surgeries that have been documented by a physician and all of those non-physician practitioners, right? So anytime I say physician, think nurse practitioner, physician assistant, any of those folks that are allowed under state licensure law to diagnose. And that would have to have occurred within the last 30 days and during the inpatient stay that preceded the party admission. The second step is to determine whether the surgery identified requires active care during the SNF. Surgeries that require active care during the SNF stay are surgeries that have a direct relationship to the resident's primary SNF diagnosis. So you're looking back at I-0020B. You're not going to include conditions that have been resolved or don't affect the resident's current status and don't drive the patient's or the resident's plan of care. So you're going to check information sources in the medical record for the last 30 days to identify active surgeries. And you're going to find that information in the same areas that we talked about already. So transfer documents, discharge summaries, progress notes, other resources that you have available to you. And again, remember, whatever is communicated verbally should be documented in your medical record and aligned with the care that the resident's going to receive. So how do you determine whether a surgery should be coded as requiring active care during the SNF stay? Well, there may be specific documentation in the medical record that indicates the SNF stay is for treatment related to the surgical procedure. This may be documented again by a physician or those non-physician practitioners. A determination of whether a surgery should be coded as requiring active care during the SNF stay can also be made even if there is no specific documentation, but the complexity of the services prescribed for the resident can only be performed safely and effectively by or under the general supervision of skilled nursing and or rehabilitation staff. such as surgical wound care, for example, to monitor infection or drainage, daily skilled therapy to restore functional loss after a surgical procedure, and administration of medication and monitoring that requires skilled nursing. The reasoning here is not so much different than what it is mentioned in Section I regarding active diagnosis when there's no specific documentation. So there, for example, the manual says to look at signs and symptoms that would relate back to a specific diagnosis, like intermittent claudication for peripheral vascular disease, or a medication that was prescribed for ongoing condition that requires nursing monitoring. Okay, so let's just go over some of the key points here. Once you've determined if the surgical procedure requires active care during the SNF stay, you're going to complete items J2300 through J5000 by checking all of the surgical procedures that apply and are documented to have occurred during the last days and during that inpatient stay that preceded the resident's party admission, and that also have a direct relationship, again, to that ICD code in I0020B. And all of this has to also drive the resident's plan of care. In reference to inpatient stays at the May training, somebody asked if admission to observation stay was included in coding these items, and no. Admission to observation stay is not considered inpatient, right? A person is only considered an inpatient when they're formally admitted to the hospital by a physician. So let's look at some practice coding scenarios for J2100. So in this first scenario, Mrs. V was hospitalized for gram-negative pneumonia. Since this was her second episode of pneumonia in the past 6 months, a diagnostic bronchoscopy was performed while she was in the hospital. She also has Parkinson's disease and rheumatoid arthritis. Mrs. V was discharged from the acute care hospital to a SNF for continued antibiotic treatment for her pneumonia, and she requires daily skilled care. So how would you code J2100? Would you code 0, no, 1, yes, or 8, unknown? Okay, quite a few people already starting out with code 0, no, which is choice A. A little bit of vacillation between B and C, but looks like the majority are going for A. Okay, looks like the changes are only adding to A. So let's go on to the answer. And the answer is yes, A, code 0, no. J2100 is coded 0, no, because there is no documentation that indicates that the resident had major surgery during the prior inpatient stay before she was admitted to the SNF for continued care due to needing antibiotic treatment for her pneumonia and the requirement for daily skilled care. If we were coding I0020, it would be coded as 13, medically complex conditions. And for I0020B, the SNF ICD-10 code that the SNF could have used there is J15.6, which is pneumonia due to other aerobic gram-negative bacteria. Okay, let's try another scenario. Mr. O is a diabetic who was hospitalized for sepsis from a methicillin-susceptible Staph aureus infection that developed after outpatient bunion surgery. A central line was placed to administer antibiotics, and he was discharged to a SNF for continued antibiotic treatment and monitoring. So how would you code J2100 for this resident? Would it be A, code 0, B, code 1, or C, code 8? And again, quite a few people starting off with code A, some working on code B. Okay. And it looks like most of the changes are happening in code A. So let's move on to the next slide. And yes, the answer is code 0, no, which was choice A. So this was coded no because there was no documentation that indicated that the resident had major surgery. Neither the placement of a central line nor the outpatient bunion surgery would be considered major surgery, but the resident was admitted to the SNF for continued antibiotic treatment and monitoring. If we were also coding I0020B, 20, this would be coded as 13, medically complex conditions. And for example, since the infection was Staph aureus, the SNF would choose, in this instance, 41.01, which is sepsis due to methicillin-susceptible Staph aureus. Okay, and we have one more practice coding scenario. Mrs. J had a craniotomy to drain a subdural hematoma after falling at home, where according to the hospital discharge summary, she had a loss of consciousness of about 45 minutes. She has COPD, and she uses oxygen at night. In addition, she has moderate congestive heart failure, she's moderately overweight, and has hypothyroidism. After a 6-day hospital stay, she was discharged to a SNF for continuing care. So how would you code J2100 in this instance? Would you choose 0, no, 1, yes, or 8, unknown? We have quite a few people looking at code B. And it looks like it's mostly the majority. Okay, I think it's safe to say that we could go on to the answer slide for this one. And that's correct. Code 1, yes, is the correct response. And this would be coded 1 yes because there is documentation that indicates the resident had major surgery, which was a craniotomy. She was inpatient in an acute care hospital for at least 1 day in the 30 days prior to her admission to the SNF. The surgery did carry some degree of risk to the resident's life or potential for severe disability. If we were coding I0020, it would be coded here as 07, which is other neurological conditions. And the ICD code in I0020B might have been S06.5X2D, which is a traumatic subdural hemorrhage with loss of consciousness of 31 to 59 minutes, subsequent encounter. In this instance, you would also check J2600, which is neurosurgery of the brain, surrounding tissue or blood vessels. Okay, now we're on to section O. How's everybody holding up? Coffee kicking in? Okay. Remember that the intent of section O is to identify any special treatments, programs, or procedures that the resident received during the specified times that are within this item, within these items in section O. So the first change that you're going to see is in 0400, which is therapies. Group therapy was updated, as you well know now, from 4 to 2 to 6 as of the publishing of the SNF PPS final rule. This information was also updated in the group minutes steps for assessment, co-treatment for Part A, and modes of therapy in the group therapy Medicare Part A section of the manual. The examples in this section were also revised with using more updated years. I think a lot of them had 2010, so they updated them all to more current years. The next item that we're going to focus on is a new item, 00425, Part A therapies. This item was added due to the new PDPM payment system. This slide and the two following are snapshots of 0425, which captures for each type of therapy the number of minutes the different modes of therapy were received by the resident since the start date of the resident's most recent Medicare Part A stay, as documented in A2400B. The modes of therapy include individual, concurrent, and group therapy. Co-treatment minutes and therapy days are also included in this item. These items are only captured at the end of a resident's Part A stay on the Part A PPS discharge indicated by A0310H equals 1. So you have a section here for speech language pathology and audiology services, the same section for occupational therapy, and another one for physical therapy. The item rationale for 00425 speaks to how critically important it is for the maintenance of as much independence as possible in activities of daily living and mobility and communication is to most people. I'm thinking all of us. Functional decline, of course, can lead to things like depression, withdrawal, social isolation, breathing problems, complications of immobility such as pressure ulcer injuries and incontinence. And these, of course, all do contribute to a diminished quality of life. The qualified therapist, along with physician and nursing, is responsible to determine the necessity for and the frequency and duration of therapy services provided to residents. Rehabilitation, whether it's speech-language pathology, OT, PT, respiratory, psychological, recreational therapy, All of this can help residents attain and/or maintain their highest level of well-being and improve their quality of life. And as part of planning for care, what we're looking at in this section are only those medically necessary therapies that occurred after admission or readmission to the nursing home that were ordered by a physician or those non-physician practitioners, and based on a qualified therapist assessment and treatment plan. Those that were documented in the resident's medical record and care planned and periodically evaluated to ensure that the resident receives needed therapies and current treatment plans are effective, or those that occurred either inside or outside the facility. You can find definitions of the types of therapies listed in this section in the glossary in Appendix A of the RAI manual. Regarding the steps for assessment in this item, as I stated previously, you're going to complete this item at the end of a Part A stay on the Part A PPS discharge assessment. In order to collect the information required to complete this item, providers should review the resident's medical record, such as the rehab therapy evaluation and treatment records, recreational therapy notes, mental health professional progress notes, and you should be consulting with each of these qualified care providers. Since this item captures the entire stay, we'd be looking to obtain this information starting with day 1 all the way through to the last day of the Part A stay. So all of your calculations will be completed on the back end of your software generally, with the result being percentage of all therapies provided to the resident. If the combined amount of group and concurrent by discipline is over 25%, it would be deemed as non-compliant, and you'd receive a warning message on your validation report about that. So this slide was provided to show you how these items would be calculated manually. So if you want to perform this exercise for yourself, you can do that following the steps on this slide, or you can let your software do it for you. I mentioned these earlier, but the modes of therapy included that a resident may receive are individual, concurrent, and group. These may be provided during the same day or even during the same treatment session. When developing your plan of care, the therapist and assistant must determine the modes of therapy and the amount of time the resident receives for each mode of therapy and code it on the MDS as appropriate. The therapist and assistant should be documenting the reason for choosing a specific mode of therapy, as well as anticipated goals for that mode of therapy. For any therapy that does not meet one of the therapy mode definitions, those minutes may not be counted on the MDS. For detailed descriptions of how to code minutes of therapy and an explanation of skilled versus non-skilled therapy services, co-treatment, therapy aides, and students, please refer to these topic headings under item 00400 in section O of the RAI manual, because those would apply here as well. So I'm going to briefly go over the coding instructions for each mode of therapy for speech, occupational, and physical therapies. This information is for Part A only. As I'm sure you know, there are different rules for Part B, so this is just for Part A. So for individual therapy, that is treatment that's provided by one therapist or assistant to one resident at a time. To enter individual minutes, you're going to enter the total number of minutes of therapy that were provided on an individual basis during the entire Part A stay. So remember, from day 1 to the last day. And you're going to enter 0 if none were provided. Concurrent therapy. That is treatment of 2 residents at the same time when the residents are not performing the same or similar activities, regardless of payer source, both of whom must be in the line of sight of the treating therapist or assistant. To enter minutes for concurrent therapy, you're again going to look over the total minutes for the entire Part A stay, and if none were provided in concurrent therapy, you're going to enter 0. Group therapy is the treatment of 2 to 6 residents, regardless of payer source, who are performing the same or similar activities and are supervised by a therapist or an assistant who is not supervising other individuals. So for group minutes, again, you're going to enter all of those minutes that occurred during that Part A stay, and you'll enter 0 if none were provided. So finally, we're going to look at co-treatment, which is when 2 clinicians, therapists, or therapy assistants, each from a different discipline, treat one resident at a time with different treatments. To enter co-treatment minutes, you'll enter the total number of minutes each discipline of therapy was administered to the resident in co-treatment sessions during that entire Part A stay. If no co-treatment minutes were administered, you're going to skip to item 00430, which is distinct calendar days. Again, for all of these modes of therapy, you're going to refer to 00400 in section O for detailed definitions and examples. Okay, so now we're going to look at therapy days. Remember that a day of therapy is defined as skilled treatment for 15 minutes or more provided during the day. If you're going to use total minutes of therapy, you are going to use total minutes of therapy, so that's individual plus concurrent plus group, without any adjustment to determine if a day is counted. So if a resident receives more than one therapy discipline on a given calendar day, this may only count for one calendar day for the purposes for coding this item. For example, if a resident received 20 minutes of concurrent therapy, that day requirement would be considered met. That's nothing new, I don't think. Okay, and so coding therapy days is the same for all three types of therapy. For speech-language pathology, you're going to enter the number of days that speech-language pathology therapy services were provided over the entire Part A stay. You'll enter 0 if therapy was provided but for less than 15 minutes every day during the stay. And if the total of minutes individual plus concurrent plus group during the stay is 0, you're going to skip this item and leave it blank. So that same pattern holds true for occupational therapy. You're going to enter the number of days of OT services were provided over the entire Part A stay. You'll enter 0 if therapy was provided for less than 15 minutes every day during the stay, and if the total number of minutes, individual plus concurrent plus group, during the stay was 0, you'll just skip this item and you'll leave it blank. And again, for physical therapy, the instructions to complete are the same as SLP and OT, but for PT services. The next item we're going to look at is item 00430, distinct calendar days of Part A therapy. This item is only completed on a Part A PPS discharge assessment, and that's indicated by coding A0310H as 1. This item records the number of calendar days that the resident received speech, OT, or PT for at least 15 minutes during the Part A stay. For this item, you are going to enter the number of calendar days that the resident received speech, OT, or PT for at least 15 minutes a day during the entire SNF stay. If a resident receives more than one therapy discipline on a given calendar day, this may only count, again, for one calendar day for the purposes of coding this item. So we're going to look at this example together. Mrs. T was admitted to the SNF on Sunday, 10/6/2018, and discharged on Saturday, 10/26/2018. She received a total of 60 minutes of physical therapy every Monday, Wednesday, and Friday during the SNF stay. Mrs. T also received a total of 45 minutes of occupational therapy every Monday, Tuesday, and Friday during the stay. So if we were to plot this out on a calendar, it might look something like this. Given that the therapy services received by Mrs. T during the stay, it would be 12 distinct calendar days in which Mrs. T received therapy services, and that's what would be coded in 00430, because therapy services were provided for at least 15 minutes on 12 distinct calendar days during the stay, every Monday, Tuesday, Wednesday, and Friday. Now, some people were a little bit confused about this example at the training in May, saying that Mrs. T would not have been considered skilled because she didn't receive rehabilitation, skilled services for at least 3 days. That would be correct if that was the only skilled service she was receiving. But if she was receiving nursing skilled services, she would be skilled. Does that make sense? Okay. So it's important to remember that this item really is only capturing skilled therapy services. Okay, item 00450, resumption of therapy. Good news here, this item is no longer required by CMS. However, some states may continue to require completion of this item. It's important to know, again, your state's requirements for completing this item, and this will only be seen on the OSA. In 00500, restorative nursing, In the steps for assessment under restorative nursing, in the third step, bullets 4 and 5 have a statement included relating to not coding services that actually require the involvement of a qualified therapist. So this coding tip, this step for assessment directs providers to ensure that those services are coded in 00400 and 00425, not here in restorative nursing. Okay, looks like I'm finishing a little early. In this lesson, you learned about the updates in sections A, I, J, and O, and how to apply the coding instructions to accurately code those practice coding scenarios, which you guys did a great job on. Hopefully, it's prepared you to be able to integrate this knowledge into what you're doing at your facilities, and hopefully it will help you later on in the day when you're completing that integrated coding and PDPM case study, which we'll be doing this afternoon after John's presentation. And again, just a reminder to complete your action plan. If there's anything that you learned in this presentation that you will need to address when you turn back to your facilities, be sure to notate it in the action plan page for this particular session. And if you have any questions, please enter them into Slido. If you do, again, see any questions that are similar to your own, just upvote that question. Sometimes it may not be worded exactly as the question you want to ask, but if you think it's going to be similar, the answer might be similar, I would suggest that you upvote that question instead of entering another one. So thank you so much for your time and attention this morning. I'm going to turn it back over to Bridget.